Hello, this is Aki from Jafron marketing team. First of all, a big thanks and welcome to our hemosuction webinar themed on caring for cardiac surgery. We're proud to have perfusionists and cardiac surgery experts joining us today, and this section will explore clinical experience sharing and also protocol optimization around hemosuction technology. Now let's dive deep into the latest information on hemosuction technology. Before we start, please let me briefly introduce our agenda today. First, Dr. Carlos will share his theory and practice around hemosuction experience at Hospital University Bordet de Mer. And then Dr. Kankovian will discuss about hemosuction practice during CPB, and there will be a comparative analysis between Jafron and other filters. And for the final 10 minutes, there will be a Q&A section, and we warmly welcome any one of you to share your question in our chatting board. And there will also be a brief summary in terms of this webinar. At the end, now it's my pleasure to introduce our first speaker, Dr. Carlos Garcia Camacho. He is a senior perfusionist at Hospital University Bordet de Mer in Spain. He was a vice president of Spanish Association of Perfusionists with over 35 experience as a perfusionist at a hospital. I think Dr. Carlos should be the leading voice in cardiac surgery section. So now please warmly welcome Dr. Carlos to share his perspective to us. Dr. Carlos, please take your time and I will stop the sharing and you can share your screen right now.
Thank you, Saki. I want to tell you something. Because today I'm not the president. I have changed my profession. So.
Okay, you have the experience as a person.
Don't worry. I'm going to start my presentation. Sorry. Can you see?
Yes, of course, I can see you.
Oh, it's okay.
Perfect.
Well, good morning. My name is Carlos Garcia, and I am perfusionist at the Puerta del Mar University Hospital in Cádiz, Spain. First of all, I would like to thank Jafron General and Neko Yao in particular for the opportunity to share with you all our hemosorption protocol with the HA380 cartridge and sharing this morning with Dr. Cacoveanu. For today, I have set myself a series of objectives that are displayed on the screen so that I can share our experience with you. Systemic inflammatory response during extracorporeal circulation is a significant clinical concern, often leading to complications. Understanding its definition, underlying mechanisms, and common outcomes is critical for effective management during cardiac surgeries and other procedures. Systemic inflammatory response is a complex physiological reaction involving widespread activation of immunomediators during extracorporeal circulation. Clinically, it can result in organ dysfunction and increases morbidity, making its recognition and management essential in patient care. Extracorporeal circulation activates various pathways, including complement cascade, cytokines release, and leukocyte activation. These mechanisms collectively contribute to endothelial dysfunction, capillary leak, and systemic inflammation, complicating patient outcomes. Complications arising from systemic inflammation during extracorporeal circulation include multiple organ failure, coagulopathy, and prolonged EQ stays. Early detection and management influence morbidity and mortality rate in affected patients. Endocarditis surface, the systemic inflammatory respond during extracorporeal circulation, understanding the disease's pathogenesis and its effect on inflammation is vital to mitigate risk during surgical interventions. Endocarditis is an infection of the heart valve of endocardial surface, characterized by microbial colonization and immune activation. This pathology triggers a sustained inflammatory response that complicates extracorporeal procedures. Patients with endocarditis experience amplified cytokine release and immune activation during extracorporeal circulation, increasing the severity of the system inflammation and the risk of adverse events post-surgery. The heightened inflammatory response in endocarditis patients can lead to increased organ dysfunction, prolonged recovery, and higher mortality rates. Identifying and managing these risks is essential for improving patient outcomes. Hemasorption is an emerging therapeutic approach to reduce systemic inflammatory by removing circulation inflammatory mediators. The Jafron HA380 cartridge is a device designed to specifically target and absorb this substance during extracorporeal circulation. Hemasorptions involves passing blood through a cartridge containing absorbing materials that bind and remove cytokines and other inflammatory molecules, reducing the systemic inflammatory load and potentially improving clinical status. The Jafron cartridge utilizes biocompatible absorbent bed with high surface area to effectively trap a broad range of cytokines and inflammatory mediators. It integrates seamlessly into extracorporeal circuits with minimal impact of hemodynamic. The cartridge is generally safe with minimal adverse effects reported. However, limitations include potential removal of beneficial molecules and the need for further large-scale study to confirm long-term efficacy and optimal treatment protocols. Clinical trials and studies have evaluated the impact of the cartridge on inflammation and patient recovery in endocarditis case recurring extracorporeal circulation, offering insight into its potential benefits and applications. Use of the HA380 cartridge has been associated with decreased inflammatory biomarkers, shorter EQ state, and improved hemodynamic stability, indicating a positive impact on patient recovery trajectory. Use the cartridge has been associated with decreased inflammatory biomarker shorters. Addressing unresolved question regarding optimal timing patient selection and long-term outcome of hemasorption will guide future improvements. Emerging technologies may expand the therapeutic potential of systemic inflammatory management. Key gaps include understanding the precise impact of immune balance, potential side effects, and integration with other therapies. Research is needed to optimize protocols and define patient populations that benefit most. Beyond endocarditis, hemasorption may have application in sepsis, trauma, and other inflammatory conditions, representing a promising area for expanding the use of devices like the HA380 cartridge. Innovation in absorbing materials, combining therapies, and personalized medicine approach are on the horizon, offering potential to enhance efficacy and safety in management system inflammatory response. In conclusion, we must keep in mind that the systemic inflammatory response during extracorporeal circulation, particularly when exacerbated by endocarditis, presents significant clinical change. Hemasorption using the Jafron cartridge offers a promising strategy to mitigate inflammation and improve outcome, although further research is essential to optimize this application. This is our system for utilizing convection and absorption techniques during extracorporeal circulation. This is the flow in our system. The cartridge is integrated into the extracorporeal circuit, typically in parallel with the hemofilter. Sorry. Okay. In parallel with the hemofilter. Is compatible with cardiopulmonary bypass and continuous organ replacement therapy. In the blood flow is driven by the ECC pump, and the cartridge is placed post-oxygenator. Our circuit design allows for the implementation of a convection and absorption techniques, either jointly or independently, simply by opening closing clamp. So if we have open excuse me. Now better. So if we have closed this clamp, the blood came from the cartridge directly to the reservoir. But if we have this open and this closed, first the blood go through the cartridge, then the hemofilter, and back to the oxygenator. So it's depending on the surgery that we can have both therapy or only one. Generally, when we have in a very, very long cardiac procedure, sometimes we have to close this clamp because we only need the hemabsorption cartridge. The flow rate recommended for the therapy is more or less from 200 to 450 milliliters a minute, and the lower flows, less than 200 milliliters, may reduce the absorption efficiency. And higher, there are risks of shear stress and reduce the contact of the blood with the cartridge. Contact time between blood and resin is crucial for cytokine removal. Adequate flow ensures efficient absorption of inflammatory mediators, prevention of clotting of stagnation inside the cartridge, and stable hemodynamic during extracorporeal circulation. Pressure monitoring is essential. Inlet pressure should remain below 300 milliliters of mercury. Excessive resistance must indicate closing of saturation. Anticoagulation, in our case is heparin, is often required for maintaining flow and prevent cartridge occlusion. We use convection techniques in all cases, combining with absorption techniques in prolonged surgeries. For example, aortic arch surgery, endocarditis, etc. We have here our protocol of hemabsorption. And in conclusion, the systemic inflammatory response associated with extracorporeal circulation varies according to the surgical context and the patient clinical condition. While convection alone may be sufficient in a standard cardiac procedure to maintain baseline inflammatory control, more complex scenarios, such as prolonged surgery, infective endocarditis, aortic arch surgery, require the combined use of convection and absorption techniques. This integrated approach enhances inflammatory modulation and may lead to improved clinical outcomes. This is a case report with the use of Jafron A380 absorption cartridge during surgery for protected mitral and aortic valve endocarditis. It focuses on how this technology helps manage the severe inflammatory response associated with infection and complex valve replacement procedure. The patient profiles include significant risk factors such as active cancer treatment and a prior history of prostatic valve infection. This factor complicates the clinical picture and necessitate careful surgical planning and postoperative management. This slide focused the acute clinical presentation that prompted urgent surgical intervention. Signs of systemic infection and respiratory compromise highlight the severity of the patient's condition. The result established the infection inflammatory burden before surgery, leading to the decision to use hematoxin to control cytokine stored intraoperatively during the surgery. The surgical plan addresses both infected valve urgently, employing CPV. The approach focuses on thorough remove the infection source and replacement with bioprosthesis valve to improve recovery. Valve replacement involves using two types of bioprosthesis. Aggressive debridement helped to reduce infection load, which is crucial in prosthesis valve endocarditis case. The extended CPV and the cross-clamp time underscore the challenging nature of the surgery. So you know that the total bypass duration was 139 and 92 minutes, and the aortic cross-clamp is worth 150 minutes. This duration can increase inflammatory response, supporting the rationale of hemorrhoic use. Hemorrhoic was integrated into the bypass, as you see in the protocol, to reduce inflammatory cytokines and complement activation, mitigating the cytokine storm, linking the prolonged CPV. This slide presents a comparison table with key clinical values before and after surgery. Before surgery preparative, we have 0.49 nanograms per liter of procalcitonin, and after surgery, immediately out of bypass, is decreased. It's the same with the interleukin cell from 81.44 to 5.30. Complement C3 from 93 to 58. And C-reactive protein from 163 to 46 milligram liters. Inflammatory and infection makers decreases significantly after the intervention with each A380 hemabsorption cartridge, evidencing the efficacy in controlling the infection process and systemic inflammation in patients with prosthesis endocarditis. Postoperative labs marked improvement and infection and inflammatory markers, suggesting effective cytokines clearance and control of systemic inflammation. The observed decrease in key inflammatory markers highlights the potential of hemabsorption to attenuate the cytokine storm during complex cardiac surgery. Complement C3 level decreases due to both surgical consumption and absorption by the cartridge. We require careful monitoring to maintain the immune balance. The case demonstrates promising results using hemabsorption in complex valve surgery, indicating benefits in inflammatory control and potential organ protection. Further research will clarify best practice. This presentation highlights the clinical benefits and practical consideration of using the each A380 hemabsorption and as an adjunct therapy in managing complicated prosthetic valve infections. Thank you very much.
Thank you for Dr. Carlos. Can you stop your sharing?
Yes. Sorry. Now, sorry.
Great, thank you. And I will share my screen right now. Okay, thank you. Thank you for Dr. Color's your sharings on hemosuction and your experience at the hospital. Your work, I think, will truly highlight the clinical values of hemosuction in optimizing the patient's outcome. And now, for all the attendees, you can scan the QR code, and to finish our attendee survey, and you will also get access to your attendee certificate if it is needed from your side. Thank you. And next, we turn to Dr. Mihai Kathleen Kakovian. He is a senior consultant in anesthesiology and intensive care. He is also specialized in high-risk cardiac surgery patients. Dr. Kakovian is highly skilled in advanced monitoring and also inflammatory management areas where our hemoabsorption play a key role there. So now let's welcome Dr. Kakovian. We look forward to your perspective. Take your time now. I will stop the sharing, and Dr. Kakovian, please share your screen right now.
Hello, everybody, and thank you for having me. It is a pleasure to be here with you. And I will start the sharing right now. Is everything okay?
Yes, it looks great. You can go ahead.
So let's dive in. My name is Kakovan Mihai Cătălin. I'm an anesthesiologist, as my friend just told you. And I also take care of the intensive care So hemoabsorption has emerged as an adjunctive therapy to mitigate these effects. A little bit about the objectives of our conversation. Just a second. We're going. Okay. So we'll have a review of the hemoabsorption practices during cardiopulmonary bypass. We'll compare the available options. We'll evaluate clinical outcomes and safety, and we will talk about highlights. Best practice. We will highlight best practices for the ICU and anesthesiology teams. So a little bit about the practices during cardiopulmonary bypass. The placement of the filter is, as my friend showed you, the filter is integrated into the cardiopulmonary bypass circuit, usually post-oxygenator. It is used intraoperatively, and sometimes, depending on the case and on the necessity, we'll extend the use of the hemoabsorption filter post-operatively, 99.9% using CRRT and 0.1% using ECMO devices. Okay, another thing that is important is the selection of the patients. High-risk patients are selected. For example, endocarditis, septic patients, ECMO, heart transplant patients. So in endocarditis, you have it's usually an emergency case. You operate without patient being fully treated with antibiotics. So you operate when the worm is at the warmest. So that means that you're going to have cytokine release. You're going to have an inflammatory response higher than usual 100% of the time. Also, septic patients that are infected besides endocarditis cases. Also, ECMO as a device being almost as a bypass pump, it engages inflammatory response less than cardiopulmonary bypass circuits, but still it does that. Practically everything that means taking out the blood of the patient and putting it into big filters, or making it outside what is a homeostatic activity, means inflammatory response, systemic inflammatory response, means higher risk of infection and, of course, coagulation problems. And of course, uh, talking about that, we have the cardiopulmonary bypass time, which is also very, very important when you talk about inflammation in cardiac surgery. So prolonged cardiopulmonary bypass time is also a reason to use hemoabsorption. This is a picture similar to my colleague. Okay, so blood flow should be 300 meters per minute, typical through the filter. We can go from 200 to 500. The duration of hemoabsorption, usually you start around over 160 minutes, 180 minutes, so around 3 hours. You keep it, you can keep it until 6 hours intracardiopulmonary bypass. Let me clarify. So the filter is placed from the beginning, but when you, what we talked about, when you presume it's going to be a long cardiopulmonary bypass time, you're going to have it installed. And of course, you can extend up to 24 hours through CRRT the hemoabsorption. The monitoring is going to be hemodynamic monitoring, coagulation monitoring, cytokine level monitoring if it's available. Of course, ejection fraction through transesophageal ultrasound. Hemodynamic monitoring is invasive, of course. It's the basic map or cardiac index, cardiac output devices in order to really have a feel of what happens with the hemodynamics of the patient. This is done by the perfusionist in the part of the perfusionist and the anesthesiologist.
7682, A7682 for my son Binti Muhammad Daris.
Sorry? Is everything okay? Okay.
Okay, doctor.
So, sorry?
Yeah, you can go ahead right now.
Okay. So, a few steps as a practical protocol. First of all, identify high-risk CPB patients. Insert the Jafron absorber into bypass circuit post-oxygenator. Initiate hemoabsorption intracardiopulmonary bypass, and continue intra and postoperatively based on clinical need. As available hemoabsorption devices, of course, we have the Jafron HA series, 280, 330, 380. We have the Cytosorb, and these two are the most common on the market. We have Biosky Hemophil and others like Oxiris for septic use, more narrow usages. As a mechanism of action, Jafron has microporous resin that is a broad spectrum absorption of cytokines, bilirubin, and myoglobin. Cytosorb is a porous polymer beads. It's a mid-range cytokine clearance. And other filters, of course, are more narrow spectrum or adjunctive use. Studies for clinical evidence in Jafron shows that Jafron has a significant interleukin and TNF-alpha reduction during cardiopulmonary bypass. It improves hemodynamic stability and it reduces the vasopressor requirements. As a comparison, clinical evidence in Cytosorb, as European trials show reduction in cytokine levels, but the outcomes are inconsistent. Some studies show no significant mortality benefit. and there is insufficient data for drawing any conclusion about cardiopulmonary bypass, because cytosorb is more rarely used in the cardiopulmonary bypass settings. Comparison evidence shows that Jafron filters often show broader cytokine clearance, bilirubin and myoglobin absorption, and several head-to-head analyses demonstrate greater reduction in inflammatory markers versus cytosorb, of course, during cardio-bypass pulmonary time. This is a table for comparative outcome times. You can see easily that during cardiopulmonary bypass, Jafron versus cytosorb has an advantage over the reduction of interleukin, tenofovir alpha, over the vasopressor requirements, ICU stay, which is also a very, very important point of view, and also the AKI incidents, the acute kidney injury incidences, that interests us very, very much, because we're talking about cardiac patients, which are elderly patients that almost all the time have a certain kidney injury or a kidney disease. Another graph that shows the same data about the interleukin and the tenofovir alpha absorption between the two filters, Jafron and cytosorb. As a safety profile, Jafron has a minimal pressure drop. It has a stable coagulation profile and no increase in hemolysis. Cytosorb, however, has occasional issues with platelet loss. But anyhow, overall, hemoabsorption is a safe measure of use with proper monitoring. I need to stress this. It is important, the platelet loss, because again, we're talking about high-risk patients. We're talking about cardiac surgery, so big surgeries that usually imply also blood loss and coagulopathy. So we need those platelets very much. As adverse effects are rare, circuit clotting or filter saturation that is easily manageable with anticoagulation adjustments and timely filter change. So in clinical outcomes, Jafron has reduced the postoperative vasoplegia, has a lower incidence of acute kidney injury, and it shortens the ICU stay in high-risk cohorts. For cytosorbs, we have mixed results in regards to cardiopulmonary bypass time usage. Some benefits in septic patients, of course, in ICU, but is less consistent with the cardiopulmonary bypass cases. The meta-analysis and the reviews, systematic reviews suggest hemoabsorption beneficial in selected cardiopulmonary bypass patients is great. Emerging data favor Jafron and in inflammatory control during cardiopulmonary bypass. Cost consideration, which is also a consideration that we like and we want. Cost considerations is important. Jafron filters are cost effective. They have low unit price versus cytosorb. They reduce ICU stay and vasopressor usage, so overall cost savings. So economic models support broader adoption of Jafron. And I personally like this characteristic of the filter of Jafron filters, because we have to be honest. Everybody in their hospital, everybody in practice, have also an economic consideration, whether it's a state hospital or private practice. We all have a part of economic considerations that we have to consider, either by not increasing the cost of the ICU stay of the patient, or just simply because we will have to have a limited amount of filters that we have. So I consider that a very, very important factor. It's better to drive with a car than with a bus every day. Okay, the limitations of current evidence. We have many studies that are observational. we need a more larger randomized controlled trials. There isn't a lot of data in pediatric surgery usages, and long-term outcomes are underreported, of course, because it's anyhow multiple factorial when you talk to high-risk patients. So it is underreported. As a summary, hemabsorption is beneficial in cardiopulmonary bypass with high inflammatory burden. So any type of high inflammatory burden patients cases that go through pulmonary bypass, from my point of view and from the literature point of view, as a summary, benefit from hemabsorption. Jafron filters demonstrate a superior cytokine clearance versus cytosorb during cardiopulmonary bypass time. Clinical outcomes favor Jafron in vasoplagia, acute kidney injury prevention, and ICU stay. Safety protocols are excellent, and cost advantages are high and support adoption. And this is, again, I stress it, a major consideration. As take-home messages, we consider that Jafron hemabsorption cardiopulmonary bypass time or high-risk patients, and we consider to integrate into perfusionist anesthesia practice more and monitor outcomes to strengthen local protocols. Thank you very much for the presentation and for the time that we have.
Thank you. Thank you, Dr. Kakovian. You can stop your sharing right now. And
I
I'll
will
share
stop
my
the
screen.
sharing. Thank you.
Thank you. Well, thank you for Dr. Kakovian's sharing. I think his sharing is majorly focused and interesting comparative analysis between Jafron and other filters. I think his experience is really beneficial to the clinical study. And also you can scan our QR code to finish our surveys, and you will also get access to and attendee certificates if it is needed. Now let's move to the next section. We open the floor for corrections right now, and please leave any message or correction in the chat board if you have anything to ask. And thank you so much. Now I will check the chatting board. Okay, we have collabed two corrections from the chatting boards. For the first one from Patrick, he asked, in which patients and how can we use it on pumps and ECMO? So the first question, Dr. Carlos, do you have anything to say in terms of this question?
Well, in which patient and how can we use? Yes, I said that almost it's perhaps in all the patients, but it's expensive for the surgery. You know, in normal case, for less than 19 minutes of surgery is necessary, but higher time is necessary because the inflammatory response exacerbates in the patient. So it's very, very necessary. In ECMO, it's dependent. It's depending of the patient. Each patient is aware. Okay, so the doctors in the care must decide if the patient needs this therapy or not. We have, for example, with patient with COVID, with grippe A, it's very, very necessary to introduce the hemabsorption cartridge during the therapy. But not all patients on ECMO. Only the infectious patient or patient that during the therapy start with an infection procedure. Okay?
Okay. Okay,
And
thank you, Doctor.
it's very easy to introduce the cartridge in both circuits, the extracorporeal circuit and in the ECMO circuit. There are a lot of images in internet and in a lot of places that you can find how you can connect the cartridge. For example, in patients after cardiac surgery, sometimes it's necessary heparin because it's bleeding the patient. So in this case, the cartridge don't need to be used because can close in the inside. Only when the patient start with heparin in the therapy. Okay, and sometimes some colleagues told me that if the cartridge must be anticoagulated before the bypass, it's necessary because the circuit is heparin inside and the patient too. So it's necessary to do that, only to wash the cartridge with 3 liters of saline.
Okay, thank you for Dr. Carlos. You have give us a comprehensive answer. And Dr. Kankovian, we have another question for you. How do you measure the blood flow through Jafron cartridge? Is it around 300 to 500 millimeter per minute?
So during cardiopulmonary bypass procedures, we have the pump. So this is a question better suited for Carlos because he's a
Okay.
perfusionist. So the cardiopulmonary bypass machine has sensors, and they have pressure sensors, and you can measure them quite well with the sensors of the machine that shows us the increasing pressure. So the start pressure that we have, the increasing pressure due to increase in pump rotation and therefore pump output, which will increase the pressure into all the circuit, and we can measure them by sensors in the machine. Also, we can find out if the cartridge is clotting or through the changing in pressure. If you keep everything constant and you have a change in pressure, then there's a problem in the filter. And usually, it's a problem of clotting, if not any high angles. What do you think, Carlos?
No, we use a monitor, call it ELSA from Transonic. Can I change? Can I say? I want to share my screen, if you don't mind. Can I do, Saki?
What?
I
Can
want
you
to.
say it
I
again?
want to share my screen.
Oh, you want to share your screen? Okay, I will stop right now and you can share.
Okay. One moment. Yes. This is our monitor. We can know all the time how what is the flow that's close about for the filter. This is from Transonic, I think. It's called ELSA. So it's exactly the flow that we can give, opening and closing the clamp through the cartridge. The problem is that this machine only have a 1/4 or 3/8 diameters of the line, but we introduce in the middle of the line a 1/4 line to make a really measure of the flow.
And decrease the pressure, yeah.
Thank you. Oh, we have lots of question comes in. Oh, the first questions May I ask
Yes.
what's your opinions for using the device during those shock surgeries around 1.5 hours? Dr. Kankovian?
Well, thank you. First of all, 1.5 hour indeed is shortest surgery. Um, the inflammatory response of the body is time dependent. It is time dependent. So from the moment you start to circulate the blood outside the veins and arteries, you're going to have a reaction of the body, and the more it stays outside, the more the inflammatory response and the coagulation factors, consumption, so on and so forth, will increase. Of course, you can use hemofilter for shorter surgeries, like 60 to 90 minutes, like the question is, but you're not going to have a very big difference, because in a 60-minute cardiopulmonary bypass time, the inflammatory reaction is not that important. You're not going to have AKI or cytokine surge um, storms because of that. Of course, you can have AKI for cardiopulmonary bypass surgeries, but most probably not because of something that the filter can remove. It's probably coming from different points of view, maybe perfusion or problems in different areas, not necessarily in cartridges. If you have enough filters, yes, you can use them, but it is again time dependent. So that is, at least now, the data shows that. So for longer surgeries, because longer surgeries imply higher cytokine release, a higher inflammatory response, a higher concentration of free hemoglobin, so on and so forth, and your most benefit is there. But again, I would not contradict you if you use it.
Okay, thank you for Doctors Kankovian's sharings. And let's see next questions from the chatting board. Oh, here is a questions for Dr. Carlos. When used with hemofilter, pass the blood through the Jafron first or not?
Yes, yes, they happen first. I explain it. Sorry, I'm going to share again the screen if you don't mind.
Mhm.
Sorry. Because it's better with a diagram.
You can share
Okay.
your screen.
Yes, now I'll try to do it. Yes. Now, you can see can you see?
Yes, it look great.
Well, the absorption filter cartridge first, because I think that during all the procedure must be connected to the patients. So at the first of the surgery, we can start with both with the hemofilter and the absorption cartridge. So the blood came here first. The cartridge of hemabsorption goes to the hemofilter and back to the oxygenator. Okay. Sorry. One moment. Now, yes. Can you see the yeah. Came here through the
Yes.
absorption cartridge, goes to the hemofilter and back to the oxygenator. If the surgery is too long, perhaps we don't need more hemofilter. So you can close this line, open this, and the blood goes through the cartridge and back to the oxygenator. So it's very important that the that the absorption filter stay first, and with a clamp here to divide the blood from the oxygenator, and is necessary to pass through the hemofilter.
Okay. Okay, thank you, Dr. Carlos. You have given us a vivid explanation.
I'm going to close this, sorry.
Okay.
I'm going to try to do it.
Never
So,
mind, you
excuse me.
can do it. I will read the question at the same time. I think this question could goes to Dr. Kankovian. He said last week a perfusionist told me that HA380 cartridge is more difficult to prime than cytosol. Is it true? I think Dr. Kankovian, you have lots of experience, right?
Yeah, sure. So a couple of questions here. First of all, during cardiopulmonary bypass time, we use heparin in high dosages. So the clotting of the hemabsorption filter is not in question, because we have to understand that hemabsorption is versatile. We can use it also in a CRRT machine, which uses a lot less heparin than we use in cardiopulmonary bypass. So as a picture, we use like let's say 40,000 international units for the beginning of the surgery, which is a lot in a bolus measure. So now we don't need to add heparin to the patient because of the filter. We usually add heparin to the patient when during the cardiopulmonary bypass time for the cardiopulmonary machine, for keeping the blood incoagulable. For the cartridge, for the HA380 priming cartridge, no. So from my point of view, cytosol cartridge and the 380 cartridge is, that's it, no difference from the point of view of priming. It's easy to prime, it's easy to use. I never felt that would be a problem for me. Well, nor did I heard about a problem like that.
Yes.
Well,
Yes.
in my experience, is the same.
Right?
Okay.
It's the same.
Thank you. Thank you. And we also have another questions from Dr. Carlos. You can answer this question. Do you sometimes have to add more heparin during longer CPB procedure?
Sorry?
Do you sometimes have to add more heparin during longer CPB procedure?
Well, you know, from the first, when I started in cardiac surgery, the procedure was very short, because only we have valve replacement, bypass for ischemia bypass only, and the time was very short. Now, almost all the surgery is very, very long, because the surgeon not only change the valve, it's had to repair, they want to prove, they want to change. So in a procedure that do 30 years ago, we have on pan 30 minutes, now we have 220 minutes. I don't know if Dr. Jacobe now is in the same opinion.
Of course.
So sometimes when we have the surgery, we know the surgeons, all the surgeons. So we said, the surgery for the surgery is very, very, very quickly. He make the surgery with a short time. But there's another surgeon that they like to repair all the things. So from 35 minutes, 20 minutes. Well, I have lived with a mitral valve replacement from 20 minutes of pump. I'm talking you this for more than 30 years. Now, before to change the valve, the surgeon start to explore all the mechanisms of the valve if he want to repair and not need to change the valve. So it's depend on the surgery, it's depend of the surgeon, it's depend of the lot of things. We have a lot of mechanisms that can change the surgery from 20 minutes to 2 hours. So sometimes with some surgeon, we start by the first with the HA 308 and 18.
Okay, thank you, doctors. Both doctors have shared your insights in terms of the heparin issue. And now do we have one more questions? I think it could be the last questions. And how about ticagrelor removal? Can hemoabsorption be beneficial to ticagrelor removal or antibiotic removal? Something like that. I think both of you could share your experience about this question. Thank you, Dr. Carlos. Could you please, you be the first one?
Well, I have experience with ticagrelor, but with aspirin, I have. So with the patient that came with integration with aspirin, the mechanism of the aspirin after surgery, it's necessary to the transfuse of platelets or less platelets. Okay, but with ticagrelor we have experience. Sorry, we haven't experience.
So we have quite a bit of experience with ticagrelor because it is in the European market as well, and it works. It works well. So if we have, for example, an aortic dissection, Stanford type A, which is a very big case, an emergency case, we have to go as fast as we can in the operating room. And we have patients that had ticagrelor, so we for sure use hemoabsorption, and it's efficient. I recommend it. It is efficient. I love hemoabsorption. If I didn't stress it enough, I think it makes you versatile and it helps you a lot during surgery and as a mentor of mine told me once, and I didn't understood it then, but surely I know it now. It told me that ICU development of a patient is the mirror of surgery. So what happens during the operating room, during the surgery, will influence, will reverberate to the ICU development of the patient. And that's why I think it's important that you do what it is right and necessary at the beginning, which is the operating room.
Okay, thank you for both doctors. Shall we answer the last questions? Just come from Onk. He said, before connecting HA to the HLM, does one need to wash the HA with saline or another crystalloid solution? Do you have any insights about these questions, doctors?
Well, we do it with saline with 3 liters, like cytosol,
Yeah.
the same.
There's no problem with that.
No
I would say
problem.
the same.
Okay. He has one more questions. Some claims that HA causes hemolysis. What is your perspective on this question?
So Carlos, please.
Oh, you can share your opinion.
From my point of view, from experience during cardiopulmonary bypass time, so in the operating theater, and also in the ICU setting, I
Mhm.
don't, I haven't seen hemolysis that is impactant to the patient. We don't. I mean, we couldn't associate important hemoglobin loss for the the filter, the hemofilter. So hemoabsorption, from my point of view, from my experience, doesn't influence
Mhm.
to such a degree that is manageable the 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 hemolysis of the patient.
Okay, Dr. Carlos, do you have
Well,
anything to add?
yes, in my experience, I think that's in excuse for don't use the
The filters, the hemoabsorption.
H8 So, yes, we use in your case a centrifugal pump, and we haven't any well, any hemolysis with or without the absorption
Exactly.
character.
Much more important from other sources than from hemoabsorption filters.
Thank you. And in ECMO, how often one needs to change a HA capsule, cartridge,
Yeah,
Doctor?
more or less each 6 hours, more or less, during the therapy.
Okay.
It depends on the therapy
It's very
and on the
easy
filter,
to
and on
change.
the change is not necessarily because of the patient, but because of the capacity of absorption of the filter. So it's per indicated from the producer.
Thank you. Thank you for doctors your answers about this heated discussion. And now let's have a move to next part. Sorry. Okay, let's have a quick summary in terms of today's cardiac uh, surgery webinar. I think hemosolutions, as both doctors said, uh, this technology offers solution to support more treatment modality and also enhance um, a good outcomes to the patients in open heart surgeries. And for Jafrons, we also have lots of study in terms of the medical study in cardiac surgery. You can take a photo of this screen and you can scan to the QR code and you can get the latest study of our hemosolution technology. And also, for 2 days later, we will also have another webinar. It is themed on pediatric webinar. We will invite for European doctors of the pediatric specific area, and you can also take us screenshots here and join our webinar 2 days later. And really a big thanks to both Dr. Carlos Garcia and Camacho, and also Dr. Kathleen Kakovian, and thanks for everyone to participate in our webinar. You can also scan to our QR code to share your feedback and also unlock your attendee certificate if you are need one. You need one. Just scan the attendee service on the screen. And also, if you would like to know more about application cases of Jafron HA cartridge, you can visit our official website on the right side QR code. Thank you so much for everyone joining us today. Thank you, Dr. Carlos and Dr. Kakovina. Thank you.
Thank you very much.
Thank you.
I appreciate to stay with you.
Thank you. Thank
It
you.
was a pleasure seeing you again, Dr. Garcia, Carlos,
Thank you very
and
much for
everybody.
all.
And thank you for the opportunity.
Thank you for all.
Dr.
Thank you for
Jacob,
all.
I appreciate to share this discussion with you. Thank you very much.
And it's beautiful to see that people are on the same page no matter where we are.
Thanks, good
Yes.
speakers.
Thank you.
Thank you
Thank
very
you,
much.
everyone.
Goodbye.
Thanks a lot.
Bye.
It was a very nice talk. Yeah.
Thank you. Bye bye.
Thank you.
Bye.
Bye bye, Doctor.